So, in the previous OT clinics video, we have discussed about pheochromocytoma. Today, we have a 36-year-old pregnant female, Gravida 1, Para 0, at 28 weeks gestation. He is admitted in the hospital because of elevated blood pressures, proteinuria, and headache. Later, he was diagnosed to have a severe preeclampsia, and the obstetricians wanted to perform an immediate delivery. Now she is at you for a preoperative evaluation. How are you going to deal with this case? But before that, when do you say the patient has preeclampsia? He should have a blood pressure of more than 140 by 90 mmHg after 20 weeks of gestation, which should be new onset. The second criteria is proteinuria. That is, a 24-hour urine collection should have 300 mg of protein, a protein creatinine ratio of 0.3 or more, and a urine dipstick should show 1 plus for protein. Alright, then what is severe preeclampsia? It includes the blood pressure more than 160 by 110 millimeters of mercury, thrombocytopenia with platelet count less than 1 lakh, serum creatinine more than 1.1 mg per deciliter, or doubling of serum creatinine in the absence of other renal disease, presence of pulmonary edema, new onset cerebral or visual disturbances, impaired liver function, that is, elevated liver enzymes, twice the baseline values, and persistent severe right upper quadrant or epigastric pain. Okay, now what lab investigations do you want to ask for this patient? Complete blood picture, especially the hemoglobin, hematocrit, and platelet count, coagulation profile, including PT, APTT, D-dimer, and fibrinogen, serum electrolytes, renal function tests, liver function tests, and screening and typing and viral serology. Okay, why do you want to ask about liver function tests and platelet counts? Because I want to rule out HELP syndrome. Okay, what is HELP syndrome? It is a severe form of preeclampsia characterized by hemolysis, elevated liver enzymes, and low platelet count. How do you define hemolysis? Hemolysis is defined by an abnormal peripheral smear and a bilirubin level more than 1.2 mg per deciliter. Alright, can you tell me some risk factors for preeclampsia? Yes, the risk factors are maternal age more than 35 years, multiple gestations, nulliparity, prior history of hypertension or preeclampsia, obesity, diabetes mellitus, chronic renal disease, systemic lupus erythematosus, and antiphospholipid antibody syndrome. And paradoxically, cigarette smoking women are associated with a relatively less risk of preeclampsia. Well, remember that preeclampsia is a dynamic disorder where the platelet counts can rapidly decrease in a very short span of time. So, it is essential to get the trends in the platelet count rather than a single report. Okay, now the patient got shifted to OT. What monitors do you want to connect? I will connect all standard ASA monitors, including NIBP, pulse oximetry, electrocardiogram, a Foley's catheter for urine output monitoring, and continuous fetal heart rate monitoring. Okay, when do you consider this patient for invasive blood pressure monitoring? I will put an arterial line when severe refractory hypertension is present, or if the patient is on vasodilators like sodium nitroprusside, or if the patient is very obese where the NIBP is not so reliable. Okay, when do you use CVP monitoring for this patient? If the patient has pulmonary edema or persistent oliguria, or there is a difficulty in fluid management. Well, is this patient on any other drugs? Yes, he is on labetalol for hypertension and magnesium sulfate for seizure prophylaxis. Now, What antihypertensives are the agents of choice for preeclampsia? Labetalol. It decreases the systemic vascular resistance without increasing heart rate. The dose of labetalol is 10 to 20 mg IV, maximum up to 220 mg IV. Then hydralazine. It has a direct vasodilating effects. The dose is 5 mg, maximum of 20 mg IV. We have nifedipine, 10 mg per oral or sublingual every 20 minutes up to a maximum of 50 mg. Nicardipine, 5 mg per hour infusion to a maximum dose of 15 mg per hour. Okay, what is the dose of magnesium sulfate for seizure prophylaxis? The commonly used regimen is 4 to 6 grams initial bolus over 20 minutes, followed by an intravenous maintenance infusion of 1 to 2 grams per hour. We need to monitor urine output, patellar reflexes, and respiratory rates during magnesium therapy. The therapeutic range for serum magnesium sulfate is 4 to 6 milliequivalents per liter. Loss of deep tendon reflexes occurs at 7 milliequivalent per liter, with widening of QRS complexes and prolonged PR intervals. Respiratory depression usually occurs at 10 milliequivalent per liter, and asystole or cardiac arrest occurs at 25 milliequivalents per liter. How do you treat magnesium sulfate toxicity? The infusion must be stopped immediately and 1 gram of calcium gluconate should be administered. If respiratory distress is present, patient may require intubation and mechanical ventilation. Alright, before we move further, can you tell me some basic pathogenesis of preeclampsia? Preeclampsia occurs due to abnormalities in the uteroplacental development. Many factors are hypothesized for this, like immunological, genetic, endothelial, platelet factors, and coagulation factors. The basic pathogenesis involves endothelial dysfunction, which will lead to increased platelet aggregation and hemolysis, increased vascular sensitivity to angiotensin and norepinephrine, increased glomerular capillary permeability, and decreased production of vasodilatory substances. Okay, now assume that you got a call from the labor ward saying that patient is throwing seizures. What would you do? Okay, turn the patient to the left side and apply jaw thrust to prevent tongue fall, administer oxygen, monitor SpO2, blood pressure and ECG, secure an intravenous cannula. If necessary, secure the airway if there is high risk of aspiration. Administer magnesium sulfate to prevent recurrent seizures. After mother is stable, deliver the baby. Okay, let's get back to our case. Do you prefer neuraxial or general anesthesia for this case? General anesthesia is less desirable because the possibility to difficult tracheal intubation secondary to airway edema is present, and hypertensive response to intubation and extubation can lead to intracranial hemorrhage. My plan is a single shot spinal anesthesia with hyperbaric bupivacaine 10 mg with 15 micrograms of fentanyl. What are the advantages of spinal anesthesia for this patient? Firstly, you can avoid difficult intubation. There is less risk of trauma to the epidural vein. The hypotension due to spinal anesthesia is typically short-lived and easily treatable with fluids, phenylephrine 50 to 100 micrograms or ephedrine 5 to 10 mg. Good. What are the clinical indications for general anesthesia and what are the special considerations in general anesthesia? The clinical indications for general anesthesia are severe maternal hemorrhage with hypotension, severe thrombocytopenia or any coagulopathy, sustained fetal bradycardia with a reassuring maternal airway examination. The special considerations during general anesthesia are administer H2 receptor antagonist and metoclopramides 30 to 60 minutes before induction. Give IV labetalol 10 mg bolus to maintain blood pressure between 140 by 90 to 160 by 110 mmHg before induction. Perform a rapid sequence induction with propofol and succinylcholine. Avoid ketamine due to its sympathomimetic properties. Remember that magnesium sulfate inhibits the release of acetylcholine at the neuromuscular junction and decreases its sensitivity at the motor end plate. Thereby, it potentiates the effects of muscle relaxants, both depolarizing and non-depolarizing. Hence, very low doses of muscle relaxants will be needed. Use a smaller size ET tube like 6 or 6.5 millimeters for intubation due to the airway edema. Provide adequate analgesia using fentanyl or remifentanil 1 microgram per kg. Okay, lastly, can methyl ergonovin be given to preeclamptic patients? No, because ergot alkaloids can lead to hypertensive crisis in these patients. So I will use oxytocin and methyl prostaglandin F2 alpha. Good. Alright, before you leave, can you name some maternal and fetal complications of preeclampsia, which you also need to monitor during the postoperative period? Yes. Maternal complications include disseminated intravascular coagulation, congestive heart failure, pulmonary edema, placental abruption, postpartum hemorrhage, acute kidney injury, rupture of the liver, intracranial hemorrhage, and septic shock. And the fetal complications include prematurity with respiratory distress, intrauterine growth retardation, meconium aspiration, small for gestation baby, intracranial hemorrhage, and oligohydramnios. Well, that's about today's case discussion, guys. So if you feel these videos are helping you, do hit the like button and subscribe to the channel. Share this video with your colleagues. Do comment the cases you want me to cover in the upcoming videos. See you in the next OT clinic session. Until then, take care. Goodbye.